The background of the challenge is very simple. You may be watching this on a tablet, on a laptop, you may be watching at 10 o'clock at night or 2 o'clock in the morning because technology allows you to do that. When it comes to booking outpatient appointments, when it comes to the interaction with the patient, we're still using paper, post and phone, which is quite inflexible and quite time consuming for patients and for staff, and we're looking to improve that in a technological era. The current process would be for a new patient, the patient will be referred by the general practitioner into a service. The service will review the referral and will be placed on a waiting list. When the patient's turn on the waiting list comes up, when there's an appointment available for them, they're then sent a letter by post to the patient's registered address, and the patient will then come to clinic on the day specified. If that day is unsuitable for them, then they have the option of phoning the booking service and trying to reschedule that appointment, but obviously that's a large volume of people trying to contact a small volume of people. When the patient does attend clinic, and they may not attend clinic, but the clinic won't know that until they fail to attend on the day, but when they do attend clinic, they may well be rescheduled for an appointment, and that appointment is often given to them the day because the medical staff are predicting the patient's need for follow-up. An outpatient is a patient who would attend a clinic appointment rather than being admitted to hospital. The term DNA means a patient who did not attend, or the alternative term is failed to attend, FTA, and those are patients who have an appointment booked to attend an outpatient appointment or other service in the NHS, but don't contact the hospital to tell them they're not coming and don't attend their scheduled appointment. The major problem is that the hospital won't know often that patients are not attending, so there's a significant cost burden because the department is there, the staffing are there, and the clinic is waiting for these patients to attend, and if they don't, all of those resources go to waste. The major benefit we perceive for patients will be flexibility. At the moment, patients are given a fixed appointment, often by post, and if that's not suitable for them, then there is time consumed trying to alter that appointment. Also, as I mentioned, patients are given a fixed return appointment, which is predicted as the case of need, and it's not always the case of people who have chronic relapsing remitting conditions. And it may be that giving them some flexibility in the return to clinic means that we see them when we need to, and we don't give them unnecessary appointments when we don't. Flexibility also in terms of how they book the appointments as well, because patients are often working shifting patterns or working long days, and being able to log on to a system later on and alter that appointment will give them greater flexibility as well. For the hospitals, obviously the loss of capacity in patients who don't attend clinics is significant and often estimated around about 10%. That's unutilised resource that is a huge cost implication for the NHS, but also an implication for the standard of patient care, as waiting times would come down if you could utilise the capacity lost by patients who fail to attend. The pilot will be based on one service in one health board, but we plan it to be a very generic solution which would easily be transferable to other specialties and then other health boards and even other countries, because many healthcare systems work in a similar way. The short-term vision is that the primary care referral system won't change, but when it comes to patients booking appointments, instead of being sent an appointment, they'll be sent an invitation to make an appointment on an easily accessible 24/7 system that allows them the flexibility to choose a time and date that suits them, and also the flexibility to change it. In the return group, the aim would be to offer them the same flexibility about making the return appointments, but also the opportunity to flex the frequency of the reviews dependent on the activity of their skin and the needs of their health problem. For the hospital, the advantage would be that patients who don't want to take up the offer an appointment simply won't, and they will be therefore utilised capacity that we're currently losing in terms of the failed to attend or did not attend. This project and process could be moved on to another level in terms of almost a triage system for patients, something that's simple, straightforward and easy for them to complete, but would direct them towards the best provider for their current issue. And that might be their general practitioner, that might be a hospital consultant, or it might be an allied health professional, but the system would allow that flexibility and direct them to the appropriate place. We need a partnership between a technological know-how and the clinical know-how to create a service or a project that works best for the NHS, for the clinicians, for the patients, and for the service itself.